Hey, and welcome to the Optimove podcast. If you're a regular listener, welcome back. In today's episode, the team sits down in a roundtable and discusses the biggest takeaways from a multi-day virtual event at the Advanced Vestibular Conference, which was hosted by the team at the University of Pittsburgh. This is a course that happens only once every 2 years and provides the leading information for vestibular specialists and cutting-edge information and research. The event featured some of the leading minds in the world of vestibular rehabilitation, and so there was no shortage of excellent insights to talk about. Some key points to listen out for in this episode are: number one, there is so much that can be done for people who have dizziness, vertigo, and balance problems, and the specialists are out there. Number two, scientists and clinical specialists in this area know so much about these problems, and so many advances have been made recently and in the past couple of years. And number three, this roundtable will talk about many reasons why it is so important for dizziness and balance problems to get addressed. And again, of course, this is by no means a comprehensive account of all the information that was shared during the conference. This just scratched the surface. But without further ado, let's get into the episode.
Our clinical team, Dr. Diana Nguyen, and then our other therapist, Peter Langlois, and then myself, Dr. Jeffrey Guild. So we're going to talk about the Advanced Vestibular course. And what this is, it's put on once every 2 years by the University of Pittsburgh, and they're a great team there. And it's basically a great team of researchers in physicians, physical therapists, psychiatrists, and all sorts of specialties that team together and basically bridge research and also clinical practice in a phenomenal way in vestibular disorders. And vestibular disorders, again, dizziness and vertigo, basically to summarize it, we see it as an underserved diagnosis, if you will. And this is not just a local problem to Dallas-Fort Worth. It's a national problem, and it's even an international problem. There's even a bunch of peer-reviewed research to support that, where this is a massive problem nationwide. So we're excited to talk about this today, this specialty, and hopefully to raise more awareness. So I'll start with my first big takeaway from this course, which was the gap between how much we know about vestibular disorders, again, basically dizziness and vertigo and balance problems, and clinical practice, what we now know and how much we can treat people with these problems. And yet when you go out into the general healthcare system, how little of that knowledge transfers over into everyday practice in healthcare. Mm-hmm. What are your guys' thoughts?
Yeah, I mean, there's a lot of research that went into that, and there was a lot of it was, either overseas or in Asia, and I saw one article that was in Australia. There's a lot of research on this, and you're right, it's not just here, but it's just everywhere globally. And yeah, there was a lot that just hard to be able to take that and be able to translate it into everything. But there was a lot of good stuff that I could take away that I can help the general public with. I mean, even this, like the small, simple things, like, having a pillow on the table to be able to help them get into for testing for, even the call pike. So just being able to get help, especially with our population, be able to help get those clients into those positions a lot easier and more comfortable. I'm like, that's brilliant. Right. I didn't even, those little things that you don't even really think about.
So basically the testing and the treatment for vertigo, it doesn't have to be as uncomfortable as it may have been all this time. The simple things, just being able to use a pillow to get people in the testing position when you're testing someone for vertigo, when you're treating vertigo, and the different maneuvers as well, of course. And that was another big thing, right?
Even treating the vertigo nowadays, they're saying that with the research, you don't have to do it as many times as you think.
Yeah.
And that's just a good takeaway too, because a lot of the clients that we see who do have vertigo, they also have a lot of difficulty maneuvering themselves and rolling around in bed.
Right. And it's kind of nice because, they're already in high anxiety, they're dizzy, they having all these other uncomfortable already.
Yes.
We don't want to try to make them more uncomfortable and trying to get them into some of these testing positions. So
when there's an alternative that might be better for them if they have neck or back pain, or if they just are very, very anxious and they don't want to be in a certain position. I mean, sometimes it's unavoidable to have to put them in a position, but it's also just building that trust with the person as well, so that they are able to feel as comfortable as possible when it gets to that point.
And this is huge. So basically what we're talking about is, so if you have vertigo, the way that you test for it and the way you treat it can involve some positioning on a therapy table or on a bed, where you have to go into some positions that provoke the symptoms, bring on the symptoms, and then the treatment is often rolling around basically on a therapy table or on a bed. And for a lot of our population, the vertigo becomes more common as people get older, and for a lot of older people, rolling in the bed is a problem in and of itself, and so it can be a significant problem for our clients and for the therapists who are treating vertigo. If that's what you're trying to get people to do. But again, the evidence supports, and this was there 2 years ago, and we even see even more maneuvers now with great evidence that there's a lot of more simple maneuvers that are able to be done that put people into much more simple positions and not as extreme positions, and the treatment for is just as good as the traditional maneuvers. And so there's a lot there that can be done. And there's a lot of education and a lot of information out there for healthcare providers. So this information is out there and can be utilized in order to help people.
Yeah. And there was a lot of really good information. So it was like,
yes,
trying to take takeaways. I'm like, all right, that was really good. That was really good. That was really good.
Mm-hmm. Yes. And what I appreciated about the course a lot too was that there were so many different disciplines, different healthcare workers who were teaching different content. So you didn't have just physical therapists. You had a neurologist, a psychiatrist, a neurooptometrist. And it's just like, even if clinically I can't do what a neurooptometrist might do, it's something that it's important for us to know, because we might need to refer out in the future. And it's just, sometimes people get to the point where they need a multidisciplinary approach. So it's just super interesting to just have like an overall general knowledge of that information.
Yeah. And it was kind of nice too, because it's like you get to see how all those things kind of play into, all right, how does, that really, breaking down, how does that really affect, all right, your macular degeneration is really kind of affecting your dizziness and your potentially vertigo, and bringing on all these other potential problems. It's like, all right,
because that could definitely affect the way we treat as well when it comes to different exercises for your eyes, for your head, like all of this type of stuff.
So I think the main takeaway from there, it is so comprehensive, right? And it can involve so many specialists. Now, and day to day, a lot of the vestibular disorders that we see, we are able to work with it just as a physical therapist. But when you get into the more complex cases, sometimes, or specific diagnoses, you do need to bring on the neurologist. You do need to bring on the optometrist or the ENT doctor. So there are a lot of different specialties that can be involved with vestibular disorders, psychiatry. And so there's a lot of different healthcare providers that can be vestibular specialists. They can be physicians, psychiatrists, physical therapists, occupational therapists. So there's a whole number of different people that can be very helpful in this area. So, and that, I think that's the other big takeaway, raising awareness and getting the information out there that there's a lot that can be done from a number of different healthcare providers. And it's, when you get to that elite, specialty where you're seeing vestibular disorders all day in and day out, you're going to see the extreme cases, right? And that's what this course also looks at. It's like, how do you find those extreme cases?
Right.
But also just kind of recognizing, talking about that. But most of the time, if you have that basic training, you know what you're doing, you've gotten mentoring from a vestibular specialist as a healthcare provider, it's not rocket science. And there's a lot of things that can be done right away to help people suffering with these problems. And then from there, just knowing when to refer to someone who's more specialized is very, very important. And for the people suffering with these problems, I think it's, there are specialists out there who know a lot about these conditions, and the vast majority of the time, these conditions are very treatable, often without medication, depends on the diagnosis. And of course, also what Dr. Furman, the neurologist, talked about, he touched on it 2 years ago, the overprescription of medications, neurological suppressants, benzodiazepines with dizziness and vertigo. It's a massive problem. And this was supported a few years ago by the Journal of Otolaryngology and Head and Neck Surgery, where they basically put their position statement out that basically stop prescribing these medications for vertigo, and even the complexity of diagnosing and treating vertigo when people are on these medications. May be okay at the very beginning when people are severely dizzy, but then once you start getting a week or two out of the dizziness, these medications tend to be more problematic than helpful.
Yeah,
creates a dependency on the medications. Whereas for physical therapy, usually we're able to get to the root cause of the problem when someone has vertigo.
Right, and I remember they mentioned if they're already on those, to just have them go off of it before treatment, before physical therapy treatment, so we can potentially get a better diagnosis and see what's really going on.
Absolutely.
And then on the opposite spectrum, we also have people who have severe dizziness and vertigo, who are extremely nauseous to the point where they may or may not throw up during their session. And so at that point, we'll usually consult with their physician and see if there's something that we can do. Usually they might prescribe something such as an antiemetic or anti-nausea medication so that the patient can basically tolerate that hour session a little more.
And we've seen that a number of times in our practice where someone's not tolerating the treatment or even the testing for vertigo, and then we call up the doctor and ask, hey, since the invention of Zofran, unbelievable how that's been able to help our clients when we can contact their doctor. Hey, we're trying to treat them for vertigo. Would it be appropriate if Zofran could be taken before we diagnose and treat? And so major difference that we've been able to see with our clients when they take that type of medication. So again, it's that interdisciplinary collaboration and planning, and sometimes it doesn't take that, but sometimes it does. And again, at the University of Pittsburgh, they have a great collaboration between a number of different disciplines, and I would also say research and clinical practice at the same time. You don't have people who are just doing research on the topic, but they're not in the clinic all the time. So these professionals are both doing research and they're practicing all the time. So Dr. Susan Whitney is the physical therapist who does a lot of research in this area, and then she's also she's in the clinic a lot as well, and so she sees it, and it's also the recognition I'm hearing from her. There's a heavy science to it. There's a little bit of an art, and a lot of where experience and just seeing it so many times over and over again, you really helps you to be able to help people to be able to relieve their symptoms, prevent falls, help their dizziness tremendously so that they can get back to the life that they want to lead.
Yes, definitely, because it's not a one-size-fits-all type of diagnosis or treatment either. It's like everybody presents differently. There are simple cases where something might be black and white. You might be able to fix it right away, but there are other times where people might have, and most of the time from what I've seen, they also have some type of underlying or residual dizziness after their vertigo is resolved. And then it's up to us to, basically assess it and see what we can do or what we can't do, and refer if we need to.
Yeah, it's always the hardest one after they still have that kind of woozy dizziness, and it's like, all right, how can I help you with that? So that's always the hard one.
And especially
what I did notice from Dr. Whitney's presentation, she brought up two really interesting points that I think everybody should kind of remember. Is that a lot of their vertigo was seasonal. And
Yes.
a lot of people don't realize that. It's like, and I didn't realize it at the time either. So it was like, she was bringing up how it could maybe be seasonal, and also, and how that would kind of related to vitamin D deficiencies. And so, it's like, well, vitamin D, okay, well, a lot of our patients who are dizzy, a majority of them are going to be women. Like, kind of, I was like putting two and two together there. I was like, oh, okay, well, that makes sense. A lot of women are vitamin D deficient, so.
Just after a certain age too, it's like your calcium and vitamin D levels, they start to go down a lot more, and that has research has shown that affects a lot of vertigo. Like there's a very, very high correlation with that, and we see that a lot in our older population.
And I think the big takeaway there is, so when I first started treating vestibular disorders about 10 years ago or more, we weren't talking about prevention. Vertigo just kind of happened. We knew, of course, it got more common with age, but that was just kind of about it. Now we know from the research, and we knew this 2, 3, 4 years ago, the connection between bone mineral density. So even to the point of, if you have a vestibular problem, screen for a bone density problem. If you have a bone density problem, screen the vestibular system, because the connection between the two systems is that strong according to the research. And that was from a few years back. And not only bone density, but also medical complexity in general. So the more medically complex a person is, the more likely they are to get vertigo. High blood pressure, thought of as also being kind of a trigger, if you will, but also just the more medically complex a person is, the more likely they are to get vertigo, even if you factor in age. But also now the seasonal thing, and this was, keeps tying all together, right? And this was brand new evidence that wasn't there 2 years ago. So I was at this course 2 years ago in person, and of course this was virtual this time around, but that evidence wasn't there 2 years ago. So now we're talking about, okay, at the beginning of spring and of winter, vertigo tends to increase because of the long season of where people are not out in the sun and aren't getting as much vitamin D as they would normally. And so that connection keeps getting closer and closer. And if you supplement vitamin D, you can reduce the risk of vertigo. You can, if you treated for someone for vertigo, the evidence well supports that if they were vitamin D deficient, you can reduce the risk of the vertigo coming back. So a lot of great research and information now that I think it's very important for family practitioners, internal medicine doctors, that they can be doing on the front end to prevent some of these problems.
Yeah. Prevention is always the most important thing, or like the best thing, in my opinion, if it's possible.
I wanted to touch base a little bit, Peter, on what you were talking about, and the treatment for vertigo. Again, so it's rolling around on a table or a bed, and what it tends to do, it tends to stimulate the brain a lot. And what a lot of people will experience is, what I usually tell people is, you might feel under the weather for a day or two after that. And because sometimes people they may not feel well for a day or two after the treatment. And that's normal, completely normal. Yep. What I see less of is if they feel great afterwards. Sometimes that happens, but more commonly they feel under the weather. And so that's what I educate them on. And so I think as healthcare providers, it's important, the education on the front end, letting them know what things are going to be like right after the treatment, and how they can get better. Another big takeaway for me was, usually we'll be able to say that, the vast majority of the time, treatment for vertigo, each canal, 1 to 3 times if you're treating it. Of course, I've seen people where it's taken 3 different maneuvers, 9 to 12 sessions that we have to see them. Not as common, and you see it more and more when you're working with a large number of people. But the vast majority of the time, it doesn't take that many different treatments, but sometimes it can. And so, of course, that can get frustrating for the healthcare provider and for the person getting treated. But again, the large number of maneuvers that we now have, and we can go to, if one form of treatment for vertigo is not working, we have others. And we don't know why or rhyme or reason which one when quite so much, but you keep trying different things until you're able to to get rid of it.
Yes. And I agree with you on the patient education aspect of that. I think it's so important. Just, telling them what vertigo is, like what the likely prognosis is, what might and might not happen, what to expect. It gives them a very big sense of calm afterwards whenever they actually know that it's treatable, because so many of them have been told that there's nothing you can do about it just because whoever has treated them in the past or has seen it, it's not as well known on the treatment or how to address vertigo.
So if someone was listening and they had some dizziness, how would they know it was vertigo?
They would have to go see a healthcare professional
to be able to determine whether because if they're listening and they don't know what their symptoms are, and they just know that they're dizzy and things are spinning around and they're having a hard time, it's like, well, they may not know, or if they have a loved one, they're having those kind of symptoms, like
being dizzy all the time is not normal. So I would definitely recommend that they go see somebody for that. Yeah. And I would also advise against looking up YouTube videos of how to treat said vertigo, because there are very different types of vertigo, and it gets a little messy.
Yeah. And it's easy to make it more complex when you're going into different canals and stuff.
And we've seen that. I recently saw a woman in her 30s. She had been repositioning herself 6 times in one day using different maneuvers from YouTube. And why you're desperate to get rid of this, and there's nobody there that can seem to help you. They just prescribe you meclizine because that's what the medical algorithm basically says to do. True story. And so you go on YouTube and you find these maneuvers. What ended up happening was she had, her testing was not normal. So she tested negative. I knew that she had vertigo though. So we actually went back and sure enough, we came back. She was positive in at least 4 canals, that had been the first time I've seen 4 canals involved. I've certainly seen 3. So basically she was getting vertigo in a number of different areas of her inner ear balance system, very likely because of the different maneuvers she was doing and going onto YouTube. And Dr. Whitney had talked about that a couple years ago at this course. And they talked about it here, the large number of more complex cases that they're seeing from people repositioning themselves from YouTube videos. But it's true, recognizing that, of course, they're not seeing the people who have made themselves better, and then, of course, don't end up coming in. But as you guys had mentioned, and I think this is important for people to know, very important to see a healthcare provider if you're experiencing vertigo, basically meaning a rotational spinning sensation, right? And of course, you're not spinning yourself around and falling on the floor and having fun with it. That's not the reason for the vertigo. But you're getting a rotational spinning sensation. One, it's not normal. And yes, the most common is benign positional vertigo. That is what we're talking about today.
Do you want to explain to our general public a little bit more about what benign positional vertigo is?
So, put simply, benign positional vertigo is basically when you have some crystals in your inner ear balance system that get into the wrong spot, and it gives your brain a false sensation of spinning. Now, this condition is the vast majority of the time very, very treatable. The other problem with this is finding the right specialist to be able to treat it, because especially if you get to older populations, you do have a higher risk for falls. And so they do need to be treated quickly and urgently. And even for people who aren't in the geriatric population, there's a huge level of debility that goes along with it, and missed time from work and missed time from being able to live one's life and to be able to interact with their family. The other problem, though, is that rotational spinning sensation of vertigo. Vertigo is a symptom. It can also be more emergent type of a problem, such as a stroke, a brain tumor, a cardiac rhythm problem. Concussion. There can be a number of different causes for a sensation of spinning or vertigo. And so very, very important to see a healthcare provider, because you also want to rule out and make sure that it's not something that's life-threatening. And another thing that they did great in this course was to be able to empower I think there were 200 people attending the course internationally, to be able to empower us to be able to screen people for those life-threatening conditions. So even if you go into a physical therapist or an occupational therapist or a psychiatrist, they are able to figure out basically if the problem is something other than an inner ear balance problem, and then refer you from there. So we need to figure out if it's a stroke, if it's a potential brain tumor, if it's multiple sclerosis, if it's these other things, and then get that person to the right healthcare provider. So very, very important for people to go to your doctor or a physical therapist if you're experiencing these symptoms, because it could be life-threatening.
Yeah. I'm really kind of impressed on a lot of the concussion stuff that they went through.
Yeah, let's dive into concussion a little bit.
Because they touched on it on two different aspects. One on they did headaches, and then the other one they did for concussions.
Yes.
And it was just kind of nice because we're starting to see a few more people with concussions. So I was like, that was pretty cool. And not only that, and then right after we did the training, I watched the movie Concussion. Have you guys seen it?
No,
I
haven't heard of it.
Oh my
either.
God. It was really good because what it did was basically took all the stuff that we kind of went through over the weekend, and then it was like, that's perfect. So I'll kind of give you a synopsis. Is a neuropathologist who basically goes through and he does autopsies. And he was doing autopsies on these ex-NFL players. And he is like, this guy has symptoms at age 50 of Alzheimer's. And, confusion, headaches, not knowing who he is and knowing that there's a problem and he doesn't know how to fix it. And the neuropathologist figures out there's, encephalopathy and then there's brain and CTE. And then they are trying to fight, against the NFL to be able to, get them to acknowledge that there's a problem.
Yes.
Right.
I think you bring up such an important point, because there are a lot of people out there who have suffered from concussions, especially elite athletes. Mm-hmm. And there's this big pressure for them to return to the field, return to doing their sport right away. Mm-hmm. And it's like, even though they want to and they might think that they're ready, it's like you have to clear them through all the protocols and everything for it to be like 100% safe for them to come back.
Right. And that's kind of what that movie kind of goes through, is like, all right, it's like, not only do you have, before there were no protocols, right. You just go, you just, okay, you can stand, you can walk, you're back on the field. Yes. But now, there's a lot more protocols, there's a lot more knowledge of that because of that. And that kind of the movie kind of brought out. But it was just kind of nice to see, like, all right, when the brain has that impact trauma, how kind of the top part of the brain kind of just shifts and kind of sloshes around, where the brain,
Jello,
like Jello, right? And then the brainstem is the one that's the stable, towards the neck, and then you have that shearing force in the middle that causes a lot of the problems. So
we have a much better understanding now of concussion than we used to, and what's very exciting too, now the protocols are not as conservative as they used to be. So now we have ways of getting people up and moving sooner, getting some basic aerobic in to be able to build people up, very early on, and to begin that journey very, very early and begin to make that progress. Whereas it used to be just basically lie in a dark room for a long period of time and allow the brain to recover. Now we know better, and they touched on a lot of that. Protocols for early intervention for concussion to be able to empower people to get moving sooner. And of course, in our population, what we tend to find is people who, let's say they were elite athletes, or say they had an auto accident or whatever it might be, and they're in their 20s and 30s now, and they're still suffering from these problems.
They might have some residual dizziness and vestibular issues as well. So it's like you still might have that those issues from your concussion, and you might not know why. It might be coming from your neck. You might have some neck pain that's contributing to the dizziness. You might have some vestibular issues. And what's really important is that you always want to rule out the neck before you do anything, because there might be, loss of blood supply to your brain or this and that, and you don't want to accidentally cause somebody to have a, an emergency room type of situation.
Right.
Yes.
And often with concussion, that's another example where it's a good collaboration between, say, physical therapy and neurology. Oftentimes, and we'll often, if they don't have a neurologist yet, we'll bring them in because oftentimes some medical management does need to be there. Similar with vestibular migraine. So basically, what we're looking at now, basically as migraines as a continuum, not as two separate diagnoses. And so if someone has had migraines for many years, eventually they tend to get dizziness. And it's a progression of the migraine, not necessarily two different diagnoses. It's all a continuous progression. And so if people have had migraines for a long time, now it's not surprising at all that later in life that they start getting a dizziness and other symptoms along with it. I want to go back to, Diana, what you talked about the neck. And so there's concussion, but then there's also what we call cervicogenic dizziness. Basically, someone has had an orthopedic neck injury,
yes,
and now their balance and their balance system is affected, and they're dizzy as well.
Yes.
Can you elaborate on that a little bit?
So basically with cervicogenic dizziness, the theory behind it is that there is something in your neck that's causing kind of like an altered sensation. So you might have, just like a little bit of a joint restriction here and there, or a little bit of pain that's kind of pulling on things that might be affecting your vestibular nerve, vestibular nucleus, just whatever that might be, affecting those signals that you're receiving and causing you to be dizzy. And sometimes it's as simple as just mobilizing again, or like people who are comfortable with it, manipulation, what people might consider as like getting your neck cracked, and to put it in layman's terms. And then there are other times where you can work more on neck stabilization, on stretching, just getting your posture correct so that you're better aligned and you're not constantly having to feel that dizziness. And so with cervicogenic dizziness, sometimes it's just as simple as that. Maybe it's just coming from your neck. Maybe that's the only thing that's causing you to be dizzy. Or maybe it's a combination of having neck pain on top of other vestibular deficits as well.
And oftentimes it requires two different specialties. Well, it usually does require two different specialties. And usually those two specialties is not the same person, if that makes sense. So the vestibular and neurological specialist is not usually an orthopedic specialist as well. They can be, but that's usually very hard to find. Sometimes treat the neck and then it's taken care of. But
yes,
sometimes it's not that simple. And it's this collaboration between the orthopedic specialist who's able to work with the neck, and then also the vestibular specialist who's able to work on the vestibular aspect. And then you're combining both together to help that person get better. I think that's another reason why there's so many people suffering with these sorts of problems. What is the cause? And if it's the neck, it could look like something else. And then how do you bring in two specialists to treat that when the diagnosis itself is so difficult to obtain in the first place?
Yes. And so with cervicogenic dizziness as well, it's not like a clear-cut test to determine whether it's this or that, but basically you're ruling out every other possible aspect that might be causing the dizziness. And then from there, once you exclude everything, that's when you can kind of make a better distinguishment, like differentiate that it is cervicogenic dizziness.
Yeah, and that we've seen that in a bunch of our patients already.
Yes. And
just that, not only just, the cervicogenic, but we're also, seeing like that combination. Mm-hmm. And that's why we got Diana.
So basically,
that good combination of both.
So basically, for people who have had they've had a whiplash injury, they've had, they have a kind of long-term neck problems, or their neck is always hurting, and they also have dizziness along with it. They have problems, watching action movies. They have problems when things move in front of their vision. If they get dizzy when they move their head, or if they restrict how much they move their head,
yes,
either because of the neck pain or because they don't want to be dizzy. Which one came first, the chicken or the egg?
And then over time, it starts to just get worse and worse because they're avoiding these movements, further deteriorating or, making their vestibular system weaker. Basically, you use it or you lose it, right?
Right.
So it's just, which came first, the chicken or the egg?
And we see that with our older population quite a bit.
Eggs.
What we'll often see is with our older clients, they don't move their head, they don't move their neck because they have neck pain, but also when they move their head and neck, then they get dizzy again, which came first. And you start probing around, asking questions, and they've been this way for years. So basically both systems have declined over time. Their neck has gotten locked up and tighter. And then also their vestibular system, their balance system, is basically not working the way it should be because they're not moving their head as much anymore.
And then I also want to bring up something that I've noticed in my own practice. Usually whenever I'm having people turn their head and neck, a lot of our clients who have, they don't tend to move their head and neck a lot. They tend to have a more forward flexed, like a forward head position. And so then when they're turning their head and neck like that, it's causing a lot of discomfort in their neck. And a simple thing you can do is just kind of correct their posture. And then once they start turning their head, it feels a lot better on them. I mean, it doesn't always, depending on, the level, the severity of it, it might not completely take it away, but it does make a very significant difference based on what the clients have said.
You'll hear a little more, crunching too, usually.
Yes.
With that,
which is normal.
Yeah,
which is normal.
And it's not. Would you call it? It's just wisdom.
It's increased wisdom. Is what it is. The crunching is increased wisdom. Amazingly, when they move their head and neck doing the vestibular exercises for a couple weeks, that crunching actually starts reducing. Maybe is the wisdom reducing? I don't know, but it's and what's happening is, so we have natural lubrication in our joints, and people hold their neck rigid, and so the joints in their neck don't move. And so then the natural lubrication that's in our joints then reduces. And so then they have more and more neck pain. And again, it's that vicious cycle. They start moving their head and neck, and then their neck pain starts reducing. The muscles tend to relax, and the lubrication fluid is there in the joints. And so they actually get less problems from their neck specifically. Now, of course, it's not always the case. Sometimes you need to bring in someone who really knows what they're doing to treat the neck. Now, it also goes back to very similar to vertigo. It can become very complex, and it might require multiple specialists and a lot of treatment, but not always. Sometimes start with just postural correction. Get someone to improve their posture and see how it goes, and see how much they can get better from there. Sometimes that may be the main thing that you need to start with.
Their muscles just get tired. Gravity takes a toll on them after 90-something years or so. And then it's like, you'll notice that too. By the end of the day, our patients are telling us that, I feel so like tall in the morning. And then towards the end of the day, they just start to slump over.
Yep.
And it's just,
and even once you are getting them and fixing the posture, you can get them into that position. The hard part is always having them keep it that way, because they don't have that musculature anymore to be able to maintain it. Mm-hmm. So it's not only getting them there, but being able to do the strengthening exercise to maintain it. And that's always the challenge.
Yes. And then that in turn will decrease their risk of falling as well.
Sure.
Yes.
Absolutely.
And then we also talked a lot about balance, falls, mobility and stuff during this course, which I thought was very interesting, especially in the older population.
Yeah, Dr. Patrick Sparto is the physical therapist and researcher in this area, and he is a lot about basically the different mechanics of walking. And I think one of the big takeaways is when we work on how the speed at which someone walks, we can improve their balance tremendously. And we have a ton of research to support that. And of course, we know that from our own clinical practice as well. When people walk faster, their balance is better. A lot of the details within let's say the walking cycle, or the details about our walking mechanics, tend to improve when we walk faster. What are some of your takeaways from the Dr. Sparto's
what
content?
I thought was really interesting was, I know we had a discussion about this, but basically not just gait speed, but gait variability. So the way you walk and how consistently you're able to walk can really affect your risk of falling. So basically, if you're kind of walking all over the place or just not taking like consistent, even steps, then that can definitely increase your chance of tripping and falling, hurting yourself. But that's clinically, that's like something that we can treat, but it's more kind of like a combination of fixing your gait speed to help with your gait variability and just keeping things consistent.
Yeah, sometimes I work that problem backwards. And in terms of fixing the variability to improve the gait speed. So
sometimes you have to isolate it.
Yeah.
Yes.
And well, I mean, I'd end up doing that a lot, kind of breaking it down to be able to isolate. All right, this muscle isn't firing to be able, and which is throwing your gait pattern off, and then kind of fixing that a little bit more is like, all right, now you're fixing your gait pattern and slowing things down so you can see it. So then once we fix the gait pattern, then we can build up that speed to get it a little bit normalized.
Yes.
And you're great, Peter, at getting people to shift their weight properly as well, which is another problem with their walking pattern. And that's also the benefit of the team collaboration that we do. I tend to be more kind of the big picture. You're very, very detailed in that collaboration together, even just within the specialty of specialties, if you will. Is tremendously beneficial, because then we can get down to that level of detail. Okay, I'm going to start with kind of the bigger picture, and then you work on those details of, well, you're not walking fast because this muscle is weak and this muscle is tight, and we need to get you weight shifting in this way, and then you'll be able to walk faster.
Right.
And that's what you do all the time, and it's tremendously beneficial. Any other big takeaways on that?
It is basically just working the same problem in two different directions.
What's the root cause, right?
You know, sometimes you work the problem forward, sometimes you work problem backwards.
Absolutely.
Yes.
Find the root cause. Then there's multiple root causes of the problem, and so you have to address it from both angles. And again, the big takeaway there's so many things that we can do to reduce fall risk. So if people are having these problems, or people are having these problems, don't stay silent. Speak up. Talk to your healthcare providers. If you're not able to get help from your healthcare providers, then go to other healthcare providers. There's a ton of things that can be done to prevent falls in the older population.
Yeah. And the biggest thing is, don't feel like you're ever stuck. I mean, and you don't have any choices, because you always have choices.
Yeah.
Because a lot of people just kind of like, well, this is what my doctor said, and this is what I'm just kind of stuck here.
It's not just old age. It doesn't have to be just old age. And exercise is a very good way to go about that. Not just for balance and strength, but also for your cognition. And so they talked about that for a little bit too. And basically, like when you exercise, there's a lot of different neurotransmitters, chemicals that are released that can help with your memory, your cognitive function, and just kind of your overall well-being. And, the way I talk about this a lot, but
please do. Because actually our clients ask about this all the time. So yeah,
the numbers on that were staggering when to say how the difference between, the patients who, when I studied that the patients who had routine exercise and the patients that didn't.
Yes.
That was significant.
Yes. And so with that, there's just so many different things that exercise can do. It helps with your memory. It releases BDNF, brain-derived neurotropic factor, which helps with memory, but it also increases your serotonin levels, this and that. They talked about this a lot in the course, but I also read a book about it. It's called Spark, and it's super interesting. And it just talks about how people basically, even test scores, like any age, your memory and your cognition, your anxiety levels, your stress levels, this and that can all be improved just through simple exercise. And it's just amazing how much something so simple can help so much. And it's a very good exercise is medicine, basically.
Yeah. And not only that, but I mean, just that routine exercise is always good, because even when I'll tell this a lot for some of my
routine, yes.
My orthopedic patients as well. It's like, if they're doing routine exercise, when a problem comes up later on in life, their recovery time is going to be drastically less. So it just kind of goes
prevention
for everything.
Yes.
Not only prevention, but just recovery after, just their recovery time is better.
I like the fact that you said routine, because consistency is also very important when it comes to exercise, physical activity. Just like whenever you're taking certain medications, you have to be consistent with it. They're not like, take this just, whenever you feel like it.
Yeah.
Well, some medications, yes, but
how many of our patients are, it's like supposed to be routine with their medications and aren't?
Oh, yes. Or with their exercises. Have you been doing your exercises?
Not as much as I used to or should be.
Yes.
Yeah, that's usually the routine response I get.
And the consistency is key for them to continue to improve or maintain where they're at.
Mm-hmm.
And what a lot of our clients will ask about it, they're concerned about their cognition. Dementia is it severely limits someone's independence. So people are very motivated to prevent these sorts of problems. And what we know from the research, how much exercise can help delay or prevent dementia from happening in the first place, or to significantly slow its progress. So that's very powerful and impactful for people, that it's not just this makes sense. We actually have the evidence to support it. And so people can be assured that, yes, if I'm exercising on a regular basis, I am preventing dementia from occurring, so I can maintain my independence for longer as I continue to get older.
Mm-hmm.
Doing whatever you can to slow down any type of degeneration in your brain and your body, just overall maintaining your health. Exercise is just the main thing to do.
Yep.
Yes.
Any other topics before we go on to, we'll touch base real quick on PPPD. We won't dig too much into it, but we'll touch on it briefly. No?
Go wild.
Oh, all right, good.
Go wild.
All right. I love it.
Bring it on. All right, come on. Let's hear it.
All right. So, I think the main takeaway from the general public, for the general public is, so in about 25 to 35% of acute vestibular disorders. So anytime a person has vertigo or concussion or vestibular migraine, an inner ear infection that makes them very, very sick and dizzy, and then they no longer are after a couple weeks. These are things that happen on a regular basis and are well recognized. What's not as well recognized is the disorders that can happen after someone is dizzy. And in 25 to 30% of cases, people will develop basically this this long-term dizziness and anxiety problem, to put it simply. And it's basically it's a basically neurologically caused anxiety along with the dizziness. And here's the big problem with it. So the diagnosis is now called PPPD, persistent postural perceptual dizziness. Don't worry about remembering the name of it, but it's basically a long-term dizziness, usually with anxiety problem. And it tends to happen when people are younger, in their 20s, 30s, 40s, 50s, at least right now. I think that it's also present in the older population, yes. And we tend to see it.
There's more research to support that now as well.
So that's exciting. And this disorder is becoming more recognized. But the problem in the past years has been these people, when they show up to their healthcare providers, they'll be labeled as malingers, meaning they're faking it. They'll be labeled as crazy, and they'll see a dozen different specialists. They're being thrown from internal medicine to ear, nose, and throat to neurology to cardiovascular to pulmonology, and then by the time they're going to see the vestibular specialist, they also have an appointment with a psychologist a week later. Now, there is a psychological component to this, but again, if you think of it as more of a neurologically caused anxiety problem, because basically the brain shifts when someone has, let's say, if they have vertigo or if they have sudden dizziness. And basically, Dr. Jeffrey Staub is a psychiatrist and main specialist in this area, and he's with the Mayo Clinic, and he gave a great presentation at this conference. And what he talks about is the brain basically doesn't shift back once it shifts. And what you get is someone who will be oftentimes very anxious. They'll walk like they're walking on eggshells or walking on ice. They're kind of furniture walking, and they walk very rigidly, and they'll have like this anxiety and panic along with this kind of long-term dizziness. Now, not every person is the same. And it can look very differently. And this disorder used to actually be about 6 different disorders that were all named something different. Chronic subjective dizziness was one of those, for example. And so the good news on this is there's a lot that can be done. There's more awareness now, and I'm seeing more awareness of it now. And basically a good combination of there's some medications that can help. So talk to your doctor about that. So the evidence supports SSRIs and SNRIs. Vestibular therapy, very, very important for treating this condition. And then sometimes you can bring in psychology along with it as well. A lot of times as physical therapists, we're able to work with people and get them much, much better within about 6 or 7 months. But it is a long haul. And we call these things basically functional. It's a functional neurological disorder, basically meaning you can't pick a lesion in the brain and say, there's the problem, like you can with a stroke or a tumor or these other things. It's you have to do imaging on a lot of different people and then compare them to quote unquote normal subjects, and then compare the data from all the imaging of all the brains. And basically there's a dramatic difference with people with PPPD compared to people without PPPD. So we do have the imaging, and we've had that for a few years now, of the shift in the brain that occurs with people with this disorder. So we're able to say that, yes, this is real. It's a true neurological disorder, and it looks like a psychological disorder, and there's a psychological component. And again, this is something that is quite treatable to a certain point, and people can get a lot of help.
One part of that, why people might think that these people are malingering, is because these people are technically not at an increased risk of falling. So you might have PPPD, but that doesn't mean that even though you feel like you have this fear that you might fall or something, it doesn't necessarily mean that you will. And unless it's for a different reason, a different cause. But that's kind of one of the main things that like a key takeaway to that is whenever you are kind of diagnosing somebody with PPPD, they said that you aren't at an increased risk of falling. And I think that's one of the reasons why it hasn't been as recognized in the older population, is because those people almost always have an increased risk of falling, but it's for a different reason.
Right. And that's where that the anxiety comes in with it, right? Because there's a high anxiety with that, and that a lot of that is what's driving the dizziness, or is it the dizziness that's driving the anxiety? Exactly. And they kind of go back and forth, and
it might be completely separate.
And they just kind of, there's that psychological component to it that really is really kind of feeds into that. So that was the interesting part about that.
And where's the line between an older person who's terrified of falling versus a neurologically caused anxiety about falling, if that makes sense? And I think that's why it gets more muddy in the older population. And we see this with our clients. We see people that look like a lot more like this disorder than your round-the-mill older person who's afraid of falling. So we do see this, and then the research is trending that way, but we'll see what happens with it. And the other problem with this disorder, and again, you can think of it as anxiety with dizziness after a vestibular event, a sudden dizziness or a sudden vertigo. If you distract the person, then they move better. That's part of the diagnosis. And so that makes it more problematic for the general healthcare provider, that if they distract the person, then they walk more normally. So then they're labeled as malingerers or crazy. And so that's another problem with it. So they're not at higher risk for falls, even though they walk not very well. Their walking changes. They're terrified of falling. They walk very more rigid, but also they move better when they're distracted. And so it's a cluster of symptoms together. So again, you can't have a very simple algorithm that says if this then this. It's a lot more holistic than that and more comprehensive than that. And then that along with, vestibular migraine or concussion. When does it become PPPD? When does it not? Because the PPPD, this chronic anxiety problem, basically emerged from an original vestibular problem. So that's also part of the challenge with it. So it's very comprehensive, and so difficult for people to get diagnosed. But again, think of the quarter of the people who get an acute vestibular problem, sudden dizziness or vertigo, they'll end up with this condition, and they'll end up suffering for months and years, looking for a solution, looking for a healthcare provider who can help them. Another big takeaway from Dr. Staub's presentation was, and I think this is new, I don't remember seeing this a couple years ago, was how beneficial just pure anxiety, dizziness because of pure anxiety, how much vestibular rehab can play a role in that situation. Whereas I don't remember that being the case before. So I'm very excited about that. So again, in the situation where I previously thought physical therapy or vestibular rehabilitation may not play a role, if it's just pure anxiety that causes dizziness, that's not necessarily the case. It's not, of course, the main solution in that case, but it's another contributing solution where vestibular rehabilitation can be helpful as a holistic approach to an anxiety problem that causes someone to be dizzy. So any thoughts on?
Well, I mean, that's just kind of, part of being a physical therapist, you're part psychiatrist as well, trying to deal with a lot of the anxiety issues and a lot of the other things just to be able to treat sometimes. So
you do what you can to calm them down and to make them feel comfortable to where you can help them with their balance, because yes, the anxiety is there. Not only that,
but you're also trying to build that trust relationship.
Yes.
And that alone, building that trust relationship is the main thing that I find to be able to be helpful, to be able to help with the anxiety.
Mm-hmm. And specific to PPPD as well.
Sometimes you still need the medication.
Oh,
and so,
well, I mean,
yes.
We're not psychiatrists, but we try to do what we can.
Yes, that and just educating them as well is super helpful with the anxiety and the dizziness.
Mm-hmm. And what I often find is, and the evidence supports this as well, and with this chronic dizziness anxiety problem, simply by providing the education about what it is and what's going on, why it's happening, people immediately already feel better once they know what's going on. And there's the cognitive behavioral component of it, and that can be ongoing, but that initial education about here's what's happening, here's why, and here's what is going to be done about it, and you will get better, and this is what we're going to do to get better. It can be a journey, and not everybody is the same, and you can overstimulate people, and this tends to happen all the time. So also, if you have this condition and you've been treated in the past for it and you were overstimulated and it made you worse,
you might be hesitant.
So either find another specialist, or that specialist they need to learn more about you. Mm-hmm. And I've overstimulated people before, and you learn from it, and then you go back. Okay, let's back it up a little bit. And then you just start more conservative than you originally planned, and then you go from there, because it's not black and white at all. You have to know about the individual person and work with that individual person. And sometimes life events happen, and all of a sudden there's a new change in the condition, because now they're going back to work, or now they're getting out in the community more. They're running more errands, and now they're dizzy all the time because they're getting overstimulated throughout the day. So then you gotta work with that. So it is this continuous process. I think a big takeaway from all of this is, one, there are things that can be done with dizziness and vertigo problems. There's a ton of information out there, both from the research and in clinical practice. There are the specialists out there that can help people with these conditions. Again, at the University of Pittsburgh, they're doing a great job of getting the research and the clinical practice together. It's a massive collaboration of different specialties. but it doesn't have to be. And it can start with the individual healthcare providers who can get people started if they dig in a little bit and learn about these conditions, and then get people started on that journey, and then know where to refer them to. And there is help out there. So, and if you're suffering with these problems, dizziness and vertigo, seek out your healthcare provider. It could be something that's life-threatening. It may not be, or it could severely impact your life, and you go on and suffering with the problem. Or if you're an older person, you're having these problems, now you're at fall risk because of dizziness or vertigo. So very, very important to get treated. So, any other thoughts?
I mean, to cover quite a bit.
I think that was a good way to wrap it up.
Yeah.
There we go. So, well, thank you so much for your time, you guys. This was a lot of fun. So,
love to do it
Thank
again.
you.
Hey everybody, this is the producer, Anmar here. If you enjoyed this episode, please leave us a review. If you want to subscribe to the Optimove podcast, head to www.podcast.optimovedfw.com. That's where you'll find links to subscribe on Spotify, Apple Podcasts, or wherever you listen to podcasts. Once again, that's www.podcast.optimovedfw.com. To learn more about Optimove, our practice, go to www.optimovedfw.com. And lastly, if you're in the Dallas-Fort Worth area, give us a call at 214-712-8242. That's 214-712-8242. Thanks for listening, and we'll catch you in the next episode.